Welcome everyone to our new webinar. This time we are going to talk about fertility preservation, and especially we're going to talk about those patients who suffers cancer and how it affects to them. Dr. Sinem Meski is going to talk with us about all the details, and she has more than 7 years of experience working in the fertility field, and she will be on charge to let us know all the details. Thank you very much. Welcome, Sineb.
Hi, Javier. Hi, Fran. Sorry.
Don't
Thank you
worry.
for this quick introduction. I will be sharing the presentation now. So there it is. Well, tonight I'm going to talk about fertility preservation for patients with cancer. Okay. So just for a start, I'm going to do a quick review of the history of egg freezing. So this is the timeline of egg freezing. So starting 1983, the first pregnancy from a frozen embryo was accomplished. And in 1986, the first pregnancy from frozen eggs using slow freeze method was reported. And in 1999, the first birth from frozen eggs using vitrification, which is a different method from slow freeze, was reported. So we had to wait almost 10 years to change the vitrification to the vitrification method. And then in 2000, the Human Fertility and Embryology Authority allowed the use of frozen eggs in fertility treatments in the UK. And 13 years afterwards, the experimental label was lifted by the American Society for Reproductive Medicine. So they judged that we had enough experience to take off that experimental label. And finally, in 2014, big companies like Facebook, Apple, Google announced that they were offering free egg freezing treatments as a benefit for the females US employees. So just to know how everything evolved. There are two kinds of indications, medical and elective egg freezing. And here we can see how everything evolved, both indications. And according to the HFEA sources, both private treatments and NHS funded treatments had increased, but especially in the private field. And starting 2012, we've seen a very huge increase of those treatments, both medical and elective. Why that increase? So basically, everything happens, everything has to do with age. So the main cause is, of course, the embryo, the embryo aneuploidy rises dramatically in women over 35 years old. So here in this graphic, we can see that live births are starting to get lower and lower from 32 years old, and miscarriages get higher starting also 32, 34 years old, whereas aneuploidies also get higher and higher with age. If you see at the age of 44 years old, the aneuploidy percentage is almost 90%. So aneuploidy is the word for genetic abnormalities in embryos. So that's what explains the most the implantation failures and miscarriages, and it's related strictly to age. So as I said, there are two kinds of indications: medical egg freezing and social egg freezing. So the medical egg freezing or the ovarian freezing if before puberty. I will explain that later. Is essentially due to cancer, aggressive medical treatments, or aggressive surgeries. The social egg freezing are non-medical egg freezing, and the indication is because women have to achieve their professional goals, or because they have financial constraints and cannot assume to be a mother at that time, or they didn't find a suitable partner. But tonight we are mostly talking about the medical egg freezing. So just some numbers about oncology or cancers. 10% of malignant tumors affect women under 45 years old, and 1% of those tumors affect women under 20 years old. So the most frequent tumors at a fertile age are breast cancer, cervix cancer, ovarian cancer, lymphomas and leukemias, sarcomas, melanomas, and brain cancer. And you have to know that breast cancer is the most frequent cancer in women worldwide, and only 6% are diagnosed in women under 35 years old. We have also noted that there's an increase of malignant tumors in teenagers over the last 30 years, mainly Hodgkin lymphomas, leukemias, and nervous system cancers. So the most common consequence of all the cancer is, of course, because of the gonadal toxicity due to all the chemotherapy, radiotherapy, and all sorts of therapies to beat that cancer. So there are different ways to preserve fertility in women with cancer. First of all, egg freezing. That's the most common and also the easiest way. There's this, first of all, a hormonal stimulation, and then we do the egg retrieval or egg collection, and then we freeze the eggs that same day. Then we have the cryopreservation of ovarian cortex. So that's mostly indicated in children and teenagers using laparoscopy, not an open surgery. We extract the ovarian cortex, almost the whole ovary, and we freeze it in order to thaw it later on and transplant it years after all the cancer, after the patient is cancer free. And then we have the embryo freezing. That depends mostly on the patient history. If there's a couple that they wish to have children together, so it's the same as egg freezing, but instead of freezing the eggs directly after retrieving them, we fertilize all of the eggs with the sperm, and then we leave the embryos for a culture to a blastocyst stage. That means a day 5 culture of the embryo prior freezing all the embryos. So this is just to let you know, to have an idea about the target number of eggs. So basically in women under 35 years old, we have less number of eggs to achieve at least one live birth. We need between 10 and 20 eggs to achieve a live birth. But obviously, when women get older, as you can see, when they reach 44 years old, they need more and more eggs in order to achieve at least one live birth. So if we want to have 50% chances of having at least one live birth, we need around 90 eggs. So that's also very important when we do a fertility treatment. So in conclusion, we need at least 15 to 20 mature eggs. in women, especially in women under 35 years old. The success rate depends on age, and of course, the more eggs we have, the more embryos we will also be able to create and generate, and also it will allow us to have more than one child. But the idea is that any amount of frozen eggs is better than no eggs at all. If we see this graphic, the IVF funnel, in women under 35 years old, as I said, we need at least 15 to 20 eggs to have then a 90% chance of survival of those eggs. And then 70% of those surviving eggs will be fertilized. And then only 40 to 50% of those fertilized eggs will become a blastocyst. And then we will have 50% chance of live births. In women over 35 years old, we usually have less eggs. Then, of course, the thawing percentage, the surviving thawing percentage is a little bit lower. It's 80% instead of 90%. The fertilizing of the eggs is 70%. It stays the same, but then the most important difference is the percentage of the blastocysts that of the embryos that gets to a blastocyst stage. It's 20 to 40% at the most instead of 40 to 50%. And then also live birth. So there's no absolute guarantee for success. And as I said, of course, we're here treating with patients with cancers, so any amount of eggs is better than no eggs, because the age of the patient when she's diagnosed with cancer is not something that the patient can control. So what depend? What's the results? What's the outcomes? To what does it depend? So it depends basically on, as I said, women's age, the number of retrieved and frozen mature eggs, because they have to be mature in order to freeze them, and also the technique that we use for the preservation. Now we use the vitrification process, and it minimizes the cellular damage, and also it depends on the expertise of the fertility clinic and the embryologist. So now we're going to see the difference between the fresh and frozen eggs. So all the studies, all the papers showed that there is no difference in the fertilization rate, 74% versus 73%. Between the clinical pregnancy rate, there's barely a difference, and also the ongoing pregnancy rate, and the survival of the vitrified oocytes is around 22%. Now, there is a difference between women who undergo the egg freezing process because the indication is elective or social, and women who undergo the freezing eggs process because of a cancer, diagnosed with cancer. So it's very controversial because we don't have enough data to do that comparison, but there is a difference in age. Usually women who have a medical indication are younger than women who do a social indication. The response to stimulation is a little bit lower in women who have a BRCA gene that is linked to all the gynecologists' cancers, like breast cancer, especially, and ovarian cancer. And then there's also a difference in the implantation rate. It's a little bit lower in women who have the medical indication. But otherwise, there are no difference in the survival of vitrified eggs. It's almost the same. And the hormonal stimulation does not increase the risk of ovarian cancer in patients with the BRCA genes, the BRCA gene. Okay. There's also no difference in the storage. So the longest period of storage that we have is resulting in a living birth for now 14 years. They can go from less than 6 months to over 5 years of storage. And as you see, the longest period is 14 years. So really, it doesn't damage the quality of the eggs. Now we're going to talk about all the egg freezing process and especially the patient journey. When a patient is diagnosed with cancer, her doctor should inform her about the egg freezing process. And that's where the first contact should be. You have to contact the clinic or the NHS will do it for the patient. It's an urgent treatment, so there's no time that we can lose. So the first visit should be done very quickly. We will, of course, do all the tests, all the personalized treatment plan, all the medical prescription, everything in that first visit in order to get ready for the treatment, for the stimulation process. Then we will do the stimulation process. So before that, of course, we have to make sure about the ovarian reserve in order to know what to expect, how many eggs we should expect. So the ovarian reserve testing involves AMH and ultrasound. And then we will do a protocol of the stimulation, the ovarian stimulation, in the safest way possible. So usually we start on day 2 or day 3 of the patient's period, patient cycle. We start with FSH or HMG hormone treatment. Then we usually prefer to use a GnRH antagonist to trigger the ovulation and do the egg retrieval. We do not recommend to use HCG for the triggering because we prefer to do a safe ovarian stimulation. So there's some particular cancers where we have to be careful, like breast cancer. The egg freezing is indicated in some stages of that cancer, stage 1, stage 2, and stage 3, before the metastasis spreads. We also recommend to do a treatment with letrozole 5 milligrams a day. That's an anti-estrogens that helps to not to have a hyperstimulation syndrome and also not to use any kind of medication that could trigger the cancer if it's hormone dependent. So from the first day of stimulation, we recommend to use letrozole. And as I said, we always try to trigger with GnRH agonists. And the hormonal stimulation, as I said before, does not increase the risk of ovarian cancer in those patients. It's very safe to do it, okay? It's a short period of time, and it doesn't increase any kind of other cancers related to the BRCA gene. In the ovarian cancer, the particular thing about that cancer is the high rates of recurrences. So it's a cancer that spreads very quickly and has also a high rate of recurrence. And also because we have two ovaries, so the bilaterality is also particular in that cancer, and especially if with the localization of that cancer, because we have to do the egg retrieval, the egg collection from the ovaries, and if the cancer occupies a lot of space in that ovaries, we won't be able to do a safe egg retrieval. And always try to do egg freezing before surgery. If surgery is done, usually we prefer to remove the whole ovary, and of course that would decrease the ovarian reserve. And if we have no ovaries, well, we cannot freeze eggs. That's the egg collection process. It's done just like an ultrasound, a vaginal ultrasound. So we use the probe, the vaginal probe, and we insert a very big syringe, very large syringe inside that probe to reach the ovaries. It's not painful because the patient is usually under anesthesia, and we just get to the follicles and we try to get all the liquid that is inside the follicles and contains the eggs. So it's a harmless and very easy process, and it's done under anesthesia. No need to get hospitalized that day, no need to have any special precaution before, and usually there is the most common side effects is just feeling cramps like in the premenstrual syndrome. So as I said before, now we are using a different kind of freezing method. So we're not doing freezing using involving water. We are now doing vitrification, and it involves using nitrogen, liquid nitrogen. That that's the key to the survival of the eggs after the thawing. So the challenges to freeze an egg or an oocyte is because the size of the egg, it's the biggest cell in the human being. It has a high water content, and of course there is a unique chromosomal arrangement, and we don't want to disturb that. So when we use the classic freezing process, since there is a high content in water in the egg, there was a formation of ice crystals. Now with the vitrification process, there is no risk for that to happen, and that's why the survival is even higher. As I said before, the common side effects are lower abdominal discomfort or swelling, liquid retention with because of the hormone stimulation, breast tenderness, mood swings, just like a premenstrual syndrome. The short term is the ovarian hyperstimulation syndrome, but that's particularly eliminated because we use the GnRH antagonist, and there's a very, very low risk of intra-abdominal bleeding. We try to do the egg puncture the safest way possible. There are no long-term side effects. Really, it doesn't affect the future fertility or ovarian reserve because we take out the eggs from that cycle. But of course, in patients with ovarian cancer, it's that cycle or no other cycle. So it doesn't really. At the contrary, we help the future ovarian reserve because we freeze those eggs before there is no ovarian reserve left after the treatments for the cancer. Okay, and And just to have an idea, because I know that sometimes the NHS system is a little bit slow, and most of the people have to go to a private clinic to do the egg freezing because of the emergency of that indication. I leave here some just to have an idea about the costs in the US. It's something that is really expensive. In the UK, well, it's the second most expensive, and in Spain, the treatments are more reasonable. And if you need more information about that, in our IVF Life group, we can send you all the information about the pricing and what it includes and what it doesn't include. So what do we do with the eggs that we do not use if at the end of the day, after the treatment, the cancer treatment, there is some oocyte that is left and the patient does get pregnant naturally and does not want to use the eggs. They can donate them if they're under 35 years old. They can donate them to research, or we can discard them. But especially since those women are treated for cancer, most of those eggs cannot be donated. Of course, you have to know that when we do treatment in our center, that doesn't mean that if you need to use those eggs in the future and you are more comfortable doing it in another country, you can also transport your eggs to another center. So now, how to choose the best clinic for egg freezing? You have to choose it according to how quickly they can give you an appointment, a well-established center with all the certifications, an experienced lab, especially in vitrification. Of course, it will depend also on the pricing and very important also the feeling you get with the doctor that will do the follow-up. So thank you for your attention, and now we'll do the question and answers parts. I leave it to Fran now.
Okay, hello everyone. I hope it has been good for you and you had all the informations. And now, as Sineb said, we are going to pass through the questions and answers session. And I remember everyone that all the questions are going to be answered by Dr. Mesky, and it is completely anonymous. Then you can keep making your questions and she will answer them. Then we're going with the first one, and
Mhm.
the first question we have is what of all the cancer types that we talk about can be more harmful for woman fertility? Sorry, can we
Yeah.
talk about again about their difference? Sorry.
Mhm. Yes. As I said, there are different types of harmful cancers depending especially on the medication that we will use, on the treatment that we will use. The chemotherapy and the radiotherapy also is very harmful to all the reproductive organs. And I think the ovarian cancer is very particular because of its localization. It's in the ovaries, that's where the eggs are produced. It spreads very quickly. The recurrence is very high rates of recurrence. So I think that's a cancer that would be harmful for a woman's fertility. But of course, the leukemias and all the lymphomas that affects especially the teenagers is also a cancer that could be very harmful because of the how aggressive we have to be with the treatments, and also because it affects especially the teenagers. So we have to act very quickly, and to me, I think that those are the most important cancers that have to be taken care of very quickly. If you have any other question, please feel free.
Sorry, Sineb. I was putting on my camera and my microphone. Okay, then for the next question, I was looking for the next one, and we have um, which technique or well, it's another question about the techniques used for preserving fertility, and the question is which technique you think is the safest and the more effective. I guess that it's about the safest for preserving our fertility, and yes, all about the effectivity.
Yes. Um, I think the safest one is the egg freezing. The cryopreservation of the cortex, of ovarian cortex, is mainly done in teenagers before puberty because the ovaries are not very large yet. They're very small and they contain a lot of follicles. So that's a better option. But essentially, it's the egg freezing. So that means a stimulation process using harmless medication, as I explained, especially with the triggering, and using also the letrozole in patients with a BRCA positive gene, and then do the egg retrieval the safest way possible without harming any other organ, and especially in patients with ovarian cancer, to be very careful with that before it spreads. So um, I think that's the best way to do it very quickly. It's 15 days of treatments, then we do the egg retrieval. And then you have your eggs frozen for at least 5 years. And then if you want to keep them frozen for more than that, you just sign a consent, and you can freeze them as long as you want.
Okay, thank you very much, Tineb, for your answer. Okay, we go right to the next one. Okay, this question is about how we have to manage our fertility. I guess that it is before suffering cancer. And the question is exactly that. When should we decide to preserve our fertility? I guess that it's about the age too, and just before suffering an illness like cancer.
Yes. I would say the sooner the better, of course. But as I said also in the presentation, when you have a cancer, you don't really have a choice. Sometimes it's just that, or then live with no eggs, and then maybe have to do some other kind of treatments in order to get pregnant, like egg donation. So the sooner the better. But especially in women who do have a choice, uh, the quality is very important. So if you decide to freeze your eggs, it better be under 35 years old. But when you are diagnosed with cancer, sometimes you don't really have a choice. So as soon as you're diagnosed, that's the first thing you have to do.
Okay, thank you very much, Sineb, again. And we are close to the end of the webinar. If you want to make your questions, it's the time. You are on time yet. And I wanted to know, Sineb, actually, that's a question from me. Um, what for one for male, how we should do for preserving our fertility, and how can be positive for us too.
For the, you mean for male patients, right?
Yeah, that's it. Sorry.
Yes. So the same thing. It's even easier for male patients because they don't. It doesn't require stimulation or hormonal treatment before freezing a sample of sperm. So and they can freeze several samples in a small amount of a short amount of time. So that's really easier for male. But of course, the cancers that affects male are different from the cancers that affects female. It's especially the testicle cancers. That's the one who affects the men's fertility. Other type of cancers, it depends on the treatment. Once again, if it requires chemotherapy or radiotherapy, uh, so as soon as they're diagnosed, once again, they have to freeze a sample or several samples of the sperm. So the key word here is time, and act quickly, and just for prevention, you can freeze your eggs anytime you want before even taking the risk of having a diagnosis of a cancer or any other disease. So the sooner, the better.
Thank you very much, Sinet, again. And we are just arriving to the end of our webinar about fertility preservation, concretely this time about patients who suffer cancer. And I would like to thank you, Sineb, for your information. And I would like to remember everyone that we will keep launching events like this one, like this last one event. Then don't hesitate to check what are we going next to do and to participate. Again, thank you very much, Sineb. I
Thank
hope you have been pleased by the questions of our public, and see you the next time.
Okay, thank you, Fran. It was a pleasure. Bye. Bye bye.
Bye bye.